Good morning, everyone. It's a pleasure to be here, and I would like to congratulate Professor Shivan Bhatia for organizing this first evolution meeting here in Miami 2019. It is a great meeting. It's a pleasure to be here and present prostate artery embolization. The topic of my presentation is optimizing technique for consistent results. Here is my disclosures. So if you want to start performing prostate artery embolization, it's really important to understand the anatomy. And one of the reasons for doing that is because you need to understand the pelvic anatomy, and also you need to have a safe procedure. And the best way to do that, if you are studying this procedure, if you are a beginner in this topic, I would suggest to use the Foley catheter. As you can see here, we usually suggest you to place a Foley catheter in the bladder before the procedure, and don't forget to remove the Foley catheter. And the reason to use this is because once you have the Foley catheter, you can fill the Foley balloon with contrast medium. And you know that once you have the Foley here filled with contrast medium, immediately below the Foley, you have the prostate and also the rectum. And once you have your catheter, as you can see here, the 5 French guiding catheter into the internal iliac artery, you can get a ipsilateral oblique view. The ipsilateral perspective usually ranges from 20 to 50 degrees with a small caudal incidence just to get this anatomy view. And if you have this, you can use the acronym that we call the proviso acronym, that is totally related to the arteries and to the branches that go directly to the prostate, that can have any relationship to the vascularization of the prostate, that we can say this: the P is the pudendal artery, the rectal, the middle rectal, the obturator, inferior vesicle, the superior vesicle. But reminded that you only will see this image if you use the oblique perspective, the ipsilateral oblique view. As you can see here, you have the Foley filled with contrast medium, and all these branches can be related to the prostate. So we also have categorized the prostatic arteries in 5 types of artery, and 95% of the arteries are divided in 4 types. We have the type 1, as you can see here. The type 1 is when the prostatic artery arises as a common trunk with the superior vesical artery, is one of the most common variation. Also, you have the type 2, as you can see here in blue. The type 2 is when the prostatic artery arises from the gluteopudendal trunk. And also, you have the type 3. The type 3, you can identify the obturator artery, and you see here the artery arising from the obturator artery. The type 2 and type 3 are the less common arteries, and the most common are the type 4, when the artery arises from the internal pudendal artery, and the other one is the most common is the type 1. So type 4 and type 1 are the most common, and you need also to remind that once you have the type 4, in 50% of the cases, you can have a rectal branch feeding the prostate and also the rectum. So it's really very important to identify this artery to avoid non-targeting embolization. Nowadays, we have stopped using DSA because we can move to 3D angio. Once we use 3D angio with cone beam CT, we are able to identify every branch that can be feeding the prostate. So you can save radiation, you also can save procedure time and contrast medium. So we do suggest to use cone beam CT. As you can see here, our protocol, when we get the arteriogram, the 3D CT, Cone-beam CT 3D arteriogram with the 5-French guiding catheter at the internal iliac artery. You can identify using the axial view, and once you identify the prostatic artery with the axial view, you can click in the prostate and also click in the catheter, and as a result of that, you identify the entire trajectory of the prostatic artery, as you can see here. And this will be an important tool and will facilitate the procedure for catheterization, because you can change the perspective during your procedure, so you can move the incidence trying to identify the best view that you can use to work with your microcatheter and also work with your microwire. So using this software with Cone-beam CT, you have a safer procedure and a faster procedure with better results, because you also can identify any other branch that could be fitting the prostate. So the technique that we described 10 years ago is the original technique. In this technique, what you usually do, you place your microcatheter here very close to the prostate before the bifurcation into the central gland, the transitional zone area, and also before the peripheral zone. You need to cross and branch to the bladder and also to the rectum to get a safer procedure. And once you have your microcatheter here in this position, you can start injecting simultaneously to deliver the embolic agents into these two areas, the central gland in the peripheral zone of the prostate, mainly because they have connections between both branches. So we also have seen that prostate embolization is really important, not only for reducing the prostate size, but also to get a reduction in the consistency of the prostate. And this we can measure using elastography. As you can see here, we can evaluate the prostate before and after embolization. And with elastography after embolization, we can get a reduction in the prostate consistent in around 30%. This mechanism is the same mechanism that we have seen when we use alpha blockers for patients with lower urinary tract symptoms. So we can reduce the consistency of the prostate, and also we can reduce the prostate size. That is the same mechanism that we usually get when we give 5-alpha reductase finasteride to our patients. So with prostate embolization, we can get these two mechanisms: reduction in the prostate size and also reduction in the consistency of the prostate with symptoms increasing. So trying to do that and trying to get much more ischemia and in prostate infarction, specifically where we have the BPH disease, we have developed and we have started to use what we call the perfect technique. That is the proximal embolization first, then embolize distal. What do we usually do? We do the original technique. We place the microcatheter in this position, and after our initial injection, doing the original technique, we advance the microcatheter deeper into the prostate, trying to reach more ischemia when we inject our embolic agents. And also, after doing the injection in this area, we navigate our microcatheter to the peripheral zone, to the capsular branches, and also we can inject it here, trying to occlude and to block any connection between the central gland and the peripheral zone. This will give more ischemia and better results. Here you can see an arteriogram. When we have here, you can see the arrow, you have the prostatic artery going to the area below the falling balloon, as you can see here. So this is intraprostatic branches. This is the posterior anterior perspective, where we can see the microcatheter, the left lobe of the prostate and several branches, intraprostatic branches feeding the prostate. So all these branches, they should be embolized. As you can see here, we have the microcatheter, we have seminal vesicles that we have crossed, avoiding non-target embolization, and we have the intraprostatic branches where we are going to embolize. So here you see that we have got stasis after doing the original technique. So we were able to embolize all these branches that we had. Here we don't see branches anymore. This is the first endpoint when we do the original technique. But pay attention that if we are able to move here, as you can see, the tip of the microcatheter, we have moved the microcatheter deeper into the prostate gland. And when we get an injection from this position, we can see other branches that should be embolized additionally to get more ischemia. So we have proved with the perfect technique that when you use it, we can get more ischemia in the prostate, more prostate reduction, and better results. And this has been published by our team from the University of São Paulo Medical School, and also from other teams that have used the same technique that we have developed. And this is the final endpoint. We have no prostatic branches here, and we only see the orange of the microcatheter and the prostatic arteries. So when we are able to use the perfect technique, we have seen much better results. Another reason to use the perfect technique is also because we have seen in patients that we needed to re-embolize. Some patients got a recurrence after 6-7 years after embolization. These patients, they came to us and said they want to do another embolization. And when we did the embolization, we saw that 1/3 of the patients, they had the capsular branch still patent. So beside the patency of the capsular branch, we saw that some arteries were recanalized. So there is another reason for us to embolize both branches, the central gland branch, where we have the transitional zone of the prostate, and the capsular branch, where we have the peripheral zone of the prostate. Both branches, they should be embolized, and if they do that, we can get better long-term results. And also, we have published this last year. So I said before, we have changed our technique to avoid radiation, to avoid contrast medium use, and also to do a faster procedure. When we are able to get cone-beam CT with 3D angio, we are also able to identify 1 or 2 branches that are feeding the prostate, as you can see here. So this is a useful tool that I do recommend for you to use and try to embolize any branch that is feeding the prostate, like in this case. Here we have a pelvic arteriogram, we have the right side, the left side, iliac arteries, and here you can see that there are 2 branches feeding the prostate. One branch here, tiny branch, is going to feed the central gland, and the other one is feeding the capsular area. So to get better results, is really important to embolize both branches and also do the perfect technique for both branches and getting better results. As you can see here, you have the central gland branch, you have the balloon here. Immediately below the balloon, you have all these branches that are feeding the median lobe, the transitional zone of the prostate. So we were able to catheterize and place the microcatheter here. And once we place the microcatheter, we can get cone-beam CT, and here to get a safer procedure and to understand the area, the region that the microcatheter is, and the region that the artery is feeding. So here you can see that we are feeding, this artery is feeding the left portion of the prostate. So here in this situation, you can perform the embolization and you can get stasis after embolization. So here you see before embolization and after embolization, so there is a devascularization. But again, it is really necessary to catheterize any branch that is feeding the prostate to get better long-term results. As you can see here, there is another branch that we are able to catheterize with the microcatheter. We see that this branch is feeding the lower portion of the prostate. See again the balloon here. Here was the area that we embolized the first, and now we have this apex of the prostate, and also we have to inject particles from here. But before injecting, we should get cone-beam CT to be sure that we are in a safe position and that we are covering the entire prostate, as you can see here when we use cone-beam CT. And that's the final arteriogram proving that there were two branches feeding the prostate. The first branch, the superior branch, that we embolized first, and the second lower branch, and the connection between both branches. So this proves that we should get into these two branches to embolize the entire prostate. Another alternative of materials that we have started to use is the balloon occlusion microcatheters. The balloon occlusion, in some publications have shown that they did not affect outcomes, mainly technical and clinical outcomes. Results were not significant regarding the volume of particles used and also the contrast medium and any kind of protective coiling. And there was improvement in the symptoms and also improvement in the post-void residual volume. But it's also important because we have seen that when we use the balloon occlusion, there's a potential for higher amount of particles injected into the prostate. And another reason for use the balloon occlusion in some patients is because, as you can see here, with the balloon down, you get an arteriogram. You see that there is anastomosis to the penile artery. And once you put the balloon up, you inflate the balloon, sometimes you can occlude this anastomosis and you can reverse the flow, getting a safer procedure. And so we can get two mechanisms when we are using the balloon occlusion microcatheter. You can avoid non-target embolization and you can inject more particles into the prostate, trying to get better results. Like in this case, when balloon occlusion microcatheter was used, we were able to identify in this region that we have staining with contrast medium and particles into the prostate. And this can be confirmed by cone-beam CT, where we see here the left lobe of the prostate filled with contrast and particles. So in conclusion, I can say that for beginners, I do suggest to place the Foley catheter with and fill it, the Foley balloon with contrast medium. And mostly if you are not familiar with this procedure and also if you don't have cone-beam CT. But do not forget to remove the Foley catheter immediately after the procedure, because patients, they void spontaneously after the procedure. It is really necessary to understand the anatomy, the types of arteries, and the number of arteries feeding the prostate, and you need to catheterize and embolize any branch feeding the prostate. Use cone-beam CT to identify the arteries and avoid non-target embolization. You should select and embolize every branch that is feeding the prostate, mostly the central gland and the capsular branch when you are able to identify. Try to do the perfect technique, because we have seen much better results when we are able to do this technique, because we can get more prostate ischemia, we can reduce the prostate size and reduce the prostate consistency. Take time to inject your embolic agent to get a safer procedure and perform prostate embolization bilaterally. Thank you so much.